So, looking around the room, this is about as socially distant as we can get, so I hope it's okay if I take this off. So I was asked to speak on a topic that's near and dear to my heart, preoperative optimization in colorectal cancer surgery, which is perhaps one of the hardest parts of enhanced recovery to do, but it is a key component of it. And one thing I promise is I will stay on time because I know we all want to get to this thing off. I have no disclosures. So, last century, in 1936, Dr. Hiram Studley noted increased mortality in patients who'd had marked weight loss before gastric surgery, as one would expect. And he noted that preparation is essential to improve outcomes. So we've known for a long time that we need to prep the patient, prepare them in some way, and more recently that has been known as by the term of optimization. If we think about outcomes and how they're measured, we typically measure them against pre-op variables, things that are immutable demographics that we can't change, age, gender, race, and stage. And when we look at outcomes and we try to explain the bad ones, I'm having trouble advancing this, then we start to look at these other factors that are patient-related and trying to explain why we have bad outcomes. So why don't we try to correct them first? And that's what optimization is about. So I'm going to run through these. Anemia. We know that it causes adverse events in both cardiac surgery and non-cardiac surgery. This particular graph just shows how different aspects of a patient's physiology can be affected by lower and lower rates of hemoglobin. Here it's listed as hematocrit, same thing. It affects respiratory failure, kidney function, cardiac function, stroke, and mortality. The American Association for Anesthesiologists now recommends a hemoglobin target between 7 and 10 grams per deciliter. Ideally, though, there is data coming out of the institution where Dilip Lobo is in Nottinghamshire in England, showing that ideally it should be more than 12 grams per deciliter. We can correct it if we have enough time before surgery. And therefore, one of the reasons why some countries have done better at optimization is because they have longer wait times before surgery. Typically in the States, we used to try to get patients to the OR as quickly as possible. Well, that's one thing we've learned during the COVID pandemic, that there are some things that can wait without harming the patient, and this gives us a time to do optimization. Oral iron can be used, but it's slow and often causes nausea and constipation. IV iron infusions used to have a bad rap, but they have far fewer complications than they used to. And between 1 and 1.5 grams in divided doses can be given within the 2 weeks before surgery, and there's some early evidence that it can be given right up to the day before surgery and still cause an improvement in post-op outcomes. Erythropoietin-stimulating agents can also have benefit, particularly for chemotherapy-associated anemia. Smoking. We know this causes higher morbidity, and it's also associated with readmission and re-op rates. If a patient stops smoking, they reduce their post-op complications by 60%. Meta-analyses have shown that each additional week of cessation decreases the risk of complications by 19%. And the optimal time period to allow for complete cessation is 4 weeks pre-op and can be achieved with counseling, pharmacotherapy, and other methods. I'm a little more brutal in my methods. I won't perform an elective operation on a patient who is still smoking. I don't necessarily delay it for 4 weeks, but they have to stop smoking. This shows some methods: nicotine replacement therapy, varenicline, and bupropion, which can be used in different classes of patients. Alcohol abuse, more than 2 units per day in a woman and 3 units a day in a man, has been associated with some increased risk of infection, cardiopulmonary complications, and also withdrawal symptoms post-operatively. Pre-op abstinence of 4 weeks has been recommended, but there isn't a lot of good evidence for this in terms of very few randomized trials, which are small. Obesity. We know that can cause post-op complications. It's standard in bariatric surgical practices to require initial weight loss to facilitate the operation, and this can often be very helpful in performing a colorectal cancer procedure. A 1-week low-calorie, low-fat diet decreases hepatic steatosis and bleeding, and short-term calorie and protein restriction has benefits in kidney donors and recipients. And it is feasible for a patient who is significantly overweight to lose at least 20 pounds in a 4-week period before an operation. Diabetes, excuse me. A hemoglobin A1C of over 8 indicates poorly controlled diabetes and increases complications. It too can be corrected if time allows. If it is not possible to correct it before surgery, one aims to have a blood glucose intraoperatively of less than 180, and post-op to keep the patient less than 150. You're probably familiar with the role of carbohydrate loading preoperatively in many ERAS protocols, and interestingly, that has not yet been properly studied in diabetic patients. ESPN, the European Society of Parenteral and Enteral Nutrition, describes nutrition disorders as malnutrition, sarcopenia, obesity, micronutrient disorders, and refeeding syndrome. Malnutrition is a lack of intake of nutrition that leads to altered body composition. And we see that in colorectal cancer patients because of issues with cancer cachexia and obstruction. Sarcopenia is a loss of skeletal mass and isn't detected in the normal fashion. You need cross-sectional imaging and look at loss of muscle mass on CT scans and other forms of imaging to determine this. This is one malnutrition screen, which basically looks at different BMI levels, how much weight the patient has lost in terms of 5%, 10%, and more than 10% increments, and if it's anticipated they will be unable to eat for more than 5 days. A score of 2 is high risk for post-op complications. This is the PON score. This is very similar to the previous one, but with the addition of an albumin level and whether or not it is less or more than 3.0. If surgery can be delayed by a few weeks, referral to a dietitian can help. Pre-op TPN, ranging anywhere from 5 to 23 days, has been shown to cause a 25% decrease in complications. Immunonutrition, another buzzword recently, has only small series, no randomized trials, and many of these are supported by the industry that makes the drinks, and therefore use of this is so far biased. If surgery can't be delayed, it's worth thinking about avoiding an anastomosis if possible and considering a stoma. Opioid use. It's helpful to screen your patients because this will help guide post-op pain management. And it's also important to remember recreational drugs, particularly with recent laws allowing the use of marijuana. If possible, pre-op weaning should be recommended. And learn what medications can be used with patients who are already on treatment for opioid use disorders if they're on treatment with Suboxone. There are a couple of narcotics that can be used for them. They will always tell you they can use the one with D, Dilaudid, but actually fentanyl can also be used. Shameless promotion. SAGES just recently was able to get our opiate avoidance website up and running, opioid.org, and this has information to help minimize using narcotics in both the pre-op, intra-op, and post-op period. So you have a chance to look at that, take a peek. Penicillin allergies are widely present in patients, approximately 10% in terms of recorded allergies in the electronic medical record. Unfortunately, the vast majority of those are not true, but it causes a change in one's usual practice for prescribing pre-op antibiotics. Using the wrong or a different second-line antibiotic protocol increases post-op surgical infections. So we try to routinely refer for penicillin allergy testing pre-op, and the vast majority of these were able to use our standard antibiotics. So there is potentially a lot that can be wrong with our patients even before we operate on them. it's helpful to try a screening tool. It's difficult to bring all this together, particularly when working with a rotating cast of residents. What we have tried to do is capture these issues when the patient is first seen and surgery is being considered. We have been able, and folks who have EPIC EMR will be familiar with dot phrases. We've used a dot phrase, just simply called it CRS Optimize, and it pulls up this. It's pre-filled with the hemoglobin level, and then we basically go through the usual function tab, F2 to tab to the next one. Is the patient anemic? And it gives levels, so you can tell whether it's yes, no. Click to the next one, whether or not the patient smokes. What's their alcohol use? What's their BMI? You can choose whatever cutoff you use, whatever cutoff you want. Whether or not diabetes is uncontrolled, and here we've entered the hemoglobin A1C level of 8. If it's more than 8, this prompts a referral for an endocrinology consult. Frailty, there are measures of this, such as the 6-minute walk and other measures. Typically, the old eyeball test also does a very good job at determining which patients are frail and might need a little extra time and conditioning preoperatively. And finally, the penicillin allergy and a referral to an allergy clinic. We've actually set up one that can frequently see the patient the same day or the following day, so this is clarified very quickly. So thank you very much for your attention, and try some optimizing. It goes a long way. Thank you.